Thank you, Beth, for that introduction. Good afternoon, everyone. It's an honor to be here today and presenting you today about the updates on the MitraClip therapy, which was recently classified as transcatheter edge-to-edge repair. Sorry, bear with me. I have no relevant financial disclosures. We will talk about mitral valve disease prevalence, the etiology and the indications, heart failure patients with secondary mitral regurgitations, the new 2020 ACC/AHA guidelines for the management of valvular heart disease. We'll also focus on the treatment path leading up to TEER, and then little key points on the pre-op screening and post-op management. So what is mitral regurgitation? It's a disease which occurs when the mitral valve fails to close completely, causing the blood flow to move backward into the left atrium. What are the symptoms? Some patients may never experience any symptoms. Others may develop heart failure symptoms such as shortness of breath, fatigue, decreased exercise tolerance, lower extremity edema, dizziness. And then there's two types of MR. Primary, which is also known as degenerative MR, and secondary or functional MR. Primary MR, basically, there's an underlying issue with the mitral valve itself. Either there's a flail leaflet, there's a mitral valve prolapse, and with secondary MR, it could be ischemic or non-ischemic. There's LV dysfunction resulting into mitral annular dilation. Basically, the leaflets are pulled apart from each other, so there's incomplete coaptation of the mitral valve. The prevalence of secondary MR is about 2 to 3 times more than the primary MR. So if you could see mitral regurgitation in US population, about 4 million of US population is diagnosed with mitral regurgitation, but only 1.5% of that population receives treatment, compared to aortic stenosis where about 940K patients are diagnosed, but it's treated about 14 to 15%. So 1 out of every 5 heart failure patient has moderate to severe or severe MR, and this is mainly the functional MR or the secondary MR. And if this is left untreated, then 1-year mortality rate is up to 57%. Basically, the worse the MR, the worse the severity, the prognosis is worse as well, the outcomes are worse in reference to heart failure hospitalization and all-cause mortality. Background about MitraClip system, it was approved by FDA in October of 2013 for the treatment of patients with primary or degenerative MR who were deemed prohibitive risk for mitral valve surgery. In March 2019, MitraClip was approved for symptomatic secondary or functional MR patients who have been on maximally tolerated guideline-directed medical therapy, and this was based on the amazing results of the COAPT trial. The EXPAND study took place after the COAPT trial, where it was a registry of patients who received the MitraClip therapy, and then the outcomes were very similar to the COAPT trial in a real-world setting. Over 100,000 patients have been treated worldwide with MitraClip therapy. I'm going to quickly show you a video about the MitraClip procedure, but just some key points: that the device is delivered via transfemoral venous route. The procedure is performed under general anesthesia under TE guidance. We use a 24 French guide catheter through which the delivery system is advanced into the left atrium via transseptal puncture. The steering and the positioning of the mitral valve above the mitral valve, and then advancing the MitraClip itself into the left ventricle. And then there is a grasping of the leaflets, assessment of the proper leaflet insertion, and that's when the clip is detached.
To function, the heart has 4 chambers: the upper right and left atria, and the lower left and right ventricles. In a healthy heart, blood flows in one direction through the heart's chambers. Delicate tissue-like structures called valves function to ensure unidirectional blood flow within. The heart has 4 such valves which regulate direction of the blood flow. The mitral valve separates the left atrium from the left ventricle and is made up of 2 thin flexible flaps called leaflets. When freshly oxygenated blood from the lungs returns to the heart, it enters the heart through the left atrium. Left atrium relaxation causes the mitral valve to open, enabling blood to travel into the left ventricle. When the left ventricle contracts, the mitral valve closes to prevent backflow. In some people, the mitral valve doesn't close tightly, causing mitral valve regurgitation. When the heart beats during contraction, the blood from the left ventricle can flow back up to the left atrium. Mitral regurgitation, MR, can be subdivided into functional and degenerative subtypes. Degenerative MR, or primary, results from anatomical abnormalities of the valve itself. In most cases, the chordae connecting the mitral valve to the papillary muscle rupture or elongate, causing leaflet prolapse. MR is a progressive disease which, if left untreated, can initiate a series of events culminating in heart failure and death. Current guidelines recommend surgical mitral valve repair or replacement in severe MR patients. For MR patients for whom surgery is not an option, minimally invasive procedures are available. MitraClip is a unique, highly maneuverable transcatheter system for mitral valve repair. This procedure avoids cardiopulmonary bypass using minimally invasive venous approach and transseptal puncture to gain access to the left atrium. MitraClip's steerable guide catheter is introduced over a previously placed guide wire. The dilator is used to gradually advance the guide into the left atrium, and the guide wire and dilator removed. The clip delivery system is advanced into the left atrium, positioning the clip above the regurgitant jet and perpendicular to the mitral valve plane. Inside the left atrium, the clip arms are open to 180 degrees and positioned perpendicular to the line of coaptation before crossing into the left ventricle. The clip is advanced into the left ventricle below the valve leaflets and retracted to grasp the leaflets. MitraClip grippers are designed to drop firmly into the clip arms, securely capturing both leaflets. Once the arms are closed, they create a double orifice within the mitral valve. Prior to clip deployment, echocardiographic imaging is used to assess procedural efficiency and leaflet capture. Prior to deployment, the MitraClip can be released and repositioned for optimal MR reduction. Once achieved, the clip is released and the full system retracted. In most cases, the transseptal puncture reseals itself and tissue ingrowth between the clip arms increases, facilitated by the polyester clip covering, which promotes healing to create a fibrous tissue bridge between the leaflets.
Okay, so now, MitraClip is in its 4th generation, and this is built on a long, robust clinical experience. And basically, it has led to a product development pipeline meant to meet the most important clinical needs. So as you can see, with the 4 sizes of MitraClip that is currently available, we can pick the right size for each patient's mitral valve anatomy. The G4, NTW, and XTW are the wider versions of the clip, and they are 50% wider in the grasping area, and which is where the leaflet coaptation is usually restored. So NTW and XTW, it's designed again to further reduce MR by only deploying 1 clip, and 50% coaptation surface area is wider. So the new 2020 guide introduces a new nomenclature where MitraClip is classified as TEER, transcatheter edge-to-edge repair. And there's also a distinction between a primary valve center and a comprehensive valve center. So comprehensive valve center like Mount Sinai offers TEER procedures based on the clinical expertise and care. So beginning in 2011, the 1-year results of Everest 2, then Everest 2 high-risk registry, Prohibitive risk DMR cohort. This has led to MitraClip being recommended as a class 2B for primary MR in 2014. After 2014, new data, 5-year results from Everest-2, the real world data from STS-TBT registry, and for secondary MR patients, COAPT and MITRA-FR data, all of which drove to 2020 new guidelines where a class 2A tier recommendation is now for primary MR, and we also unlocked a class 2A tier recommendation for secondary MR as well. So again, this is class 2A recommendation for high risk or prohibitive risk. So as you can see on the left side, 2014, patients who have been only prohibitive risk were candidate for MitraClip therapy. In 2020, it's upgraded to class 2A, and it is now allowing patients with primary severe MR with high or prohibitive surgical risk. Also, guideline-directed medical therapy is no longer needed for primary MR in this current guidelines. This is the treatment pathway leading up to TEER procedure for primary MR patients. The landmark COAPT trial, which is talking about the secondary MR, showed that the MitraClip is the only device for mitral valve disease in which heart failure patients with secondary MR who have been treated on maximally tolerated guideline-directed medical therapy, this improves heart failure hospitalization and mortality rate. The number needed to treat to save one life was 8, and then the number needed to treat one heart failure hospitalization was 3. Overall, 96.6% this device was free from any device-related complication at 12 months. Again, what is now moving on to secondary MR, what is promising is to see is that the care of these patients with secondary MR is growing based on the clinical evidence supporting the device interventions. Patients with secondary MR with persistent symptoms despite optimal GDMT are now eligible for class 2A recommendation of the TEER procedure. This is the updated medical guideline where Entresto was also a standard for treating patients with secondary MR. It's a class 1A recommendation. And also CRT in previous guidelines was part of a separate group, but now chronic reconstitution therapy is now a part of medical therapy itself in secondary MR. This is the treatment pathway for TEER for secondary MR, where a heart failure specialist will optimize the patients on guideline-directed medical therapy, and these patients will classify for 2A MitraClip therapy. Just to summarize that the MitraClip therapy, there is a clinical body of evidence gathered for over 17 years, which led to the foundation of the TEER recommendation for both primary and secondary MR. How does the new referral process work at Mount Sinai Hospital? We do get patients referred for moderate to severe or severe mitral regurgitation from a variety of sources. It could be from an interventional cardiology team. We could get a direct referral to our office. It could be from an inpatient heart failure team or a primary cardiology team. Myself will review all the clinicals, obtain the demographics, look at the echo. In terms of the heart team discussion, we classify whether it is primary or secondary MR based on the baseline transthoracic echocardiogram. And then we initiate that phone call to the patients and family to schedule their initial appointment, and then the patient is seen in the valve clinic. Pre-procedure testing, a lot of patients do come to our office with a baseline transthoracic echocardiogram. Again, that documents moderate to severe or severe mitral regurgitation. A TEE is done to further evaluate the anatomy of mitral valve. There is a consult with interventional cardiology and cardiothoracic surgeon and heart failure physician if needed for the secondary MR. Additional testings like cardiac cath, PFT, CT scans are only patient specifics, and we only do when indicated. Patients with any kind of history of GI issues, varices, any liver cirrhosis, all of them do require an additional GI or liver clearance prior to doing a TEE. Once these tests are done, our heart team meets every Monday morning. We go over all the test results, and basically we determine whether a patient is an eligible candidate for the MitraClip therapy, should just be followed up with the primary cardiologist, should be seen by the surgeon's team for mitral valve surgery, or follow thoroughly with the heart failure team for optimization of medications. It's a quick procedure. Again, it's a minimally invasive procedure. The average implantation time is only about 55 minutes. Patients usually stay in the hospital for about 1 to 2 days post-procedure. Contraindications and complications. Patients who cannot tolerate any anticoagulation or antiplatelet regimen, this would be contraindicated. Any active endocarditis of the mitral valve, rheumatic mitral valve disease, usually referred to surgery, and then any evidence for intracardiac or IVC or femoral venous thrombus. Complications, 99% of the time this procedure is very safe. Very minor complications like access site bleeding, infection, hematoma is less than 1%. Major complications like CVA, MI, any kidney injury, below 5%. Very rarely we see complications from a transseptal puncture like pericarditis, pericardial effusion, or tamponade. And even in the COAPT and Everest trials, like the complication of single leaflet device attachment, which is SLDA, where a clip just detaches itself from a leaflet, was less than 0.5%. Post-op care, as I said, usually patients do go home the next day. We do a transthoracic echocardiogram prior to discharge. Medication-wise, it's usually aspirin and Plavix. Plavix is just for the first 3 months post-procedure, unless the patient needs to be on Plavix for history of CAD. If the patient is on oral anticoagulation prior to the procedure, then we just continue the same regimen post-procedure as well. Follow up with primary cardiologist in about 1 to 2 weeks, and follow up again with heart valve clinic in 1 month and 1 year post-procedure. Patients who have received MitraClip therapy for secondary MR will also see heart failure patient post-procedure if indicated, to make sure that their medications have been optimized. In conclusion, the prevalence of MR is high, growing, and associated with poor prognosis. So many patients from primary and secondary MR who are not a candidate for surgical option need another treatment for the relief of MR. For primary MR patients who are prohibitive or high risk, TEER is safe and effective. Guideline-directed medical therapy has been shown to be effective in reducing heart failure hospitalization and mortality rate in secondary MR patients. And overall, it improves their quality of life. So the take-home point would be early identification and referral to the multidisciplinary team specializing in heart failure and transcatheter edge-to-edge repair with MitraClip is an important step to improve the prognosis of these patients. That's it. Thank you.